Good morning. Today we will deal with bullous disorders in dermatology. Now a vesicle can be defined as a fluid-filled lesion on the skin which is less than 1 centimeter, whereas a bullae is a fluid-filled lesion once again containing clear fluid which is more than 1 centimeter. The fluid in the skin can collect in various layers. When it is within the epidermis, it is termed as an intraepidermal blister, and when it occurs below the basement membrane zone, it's termed as the subepidermal blister. In the epidermis, when the fluid collection occurs just below the stratum corneum, we get a subcorneal blister, and when it occurs in the stratum spinosum, it's termed as an intraepidermal blister. Today we will be dealing with a number of autoimmune disorders wherein an antibody is produced against a known antigen present in the skin, causes its destruction, leading to the production of vesicobullous autoimmune disorders. Autoimmune disorders which give rise to intraepidermal blisters are termed as pemphigus group of disorders. Pemphigus means blister in Greek. Pemphigus can be classified broadly into pemphigus vulgaris and pemphigus foliaceus. Pemphigus vulgaris is further divided into pemphigus vegetans and foliaceus into pemphigus erythematosus. The most commonest type of pemphigus is termed as pemphigus vulgaris. Now, a little more about pemphigus vulgaris. Pemphigus vulgaris is the most common type of blistering disorder that we come across. It occurs equally in both males and females and is most commonly seen between the age group of 40 to 60. In pemphigus, antibodies are produced against desmosomes, which are cell adhesion molecules which attach one cell to the other. These antibodies are usually IgG. These antibodies cause destruction of these desmosomes, as a result of which the cells, they move apart, they become rounded, and this process is called as acantholysis, and the cells which are formed as a result of acantholysis are termed as acantholytic cells. Patients with pemphigus vulgaris, clinically they present, almost all patients or 90% of patients, they present with oral erosions. On the skin they have flaccid blisters which are usually seen above the umbilicus. Blisters may be seen on the scalp, on the face, axilla and the trunk. These blisters are flaccid, meaning that they rupture very soon, within around 2 to 3 days time, leaving behind erosions which spread periphery and fail to heal. Now, two tests, bedside tests, the Nikolsky sign and bulla spread sign, will help to distinguish an intraepidermal blister from a subepidermal blister. Now, a Nikolsky sign is usually when a tangential force is done on a normal skin close to the blister or on the normal skin away from the blister, and this force leads to the epidermis moving away from the dermis, then we term it as a positive Nikolsky sign, and this is seen only in case of an intraepidermal blister. Bulla spread sign is elicited in the following method. You mark the borders of the blister with the help of a pen, and a perpendicular force is applied from top, and if the blister spreads beyond the area that is marked, then the bulla spread sign is positive. Now, this is a picture of a patient with a flaccid blister. If you notice, here the roof is almost collapsed and hence it is a flaccid blister. This is a person with extensive pemphigus vulgaris. If you notice the large erosions in the form of a geographical map. It is usually most commonly seen above the umbilicus, but when it is a very severe form of pemphigus, it can affect the entire body. Another of one of our very serious patients. Now, the most common complications of pemphigus are pemphigus vulgaris. That's because you have large areas of erosions the patient is prone to secondary infection, and moreover these patients are treated with prolonged periods of immunosuppressants, so infection is very common, and these areas of erosions are usually oozing, so there is loss of fluid and this leads to dehydration and electrolyte imbalance. These people have a prolonged course in the hospital, and their treatment with long-term immunosuppressants brings about the side effects of the drugs. Now, how will we come about a diagnosis of pemphigus? History, the signs, the Nikolsky, the Bulla spread sign, presence of oral erosions are key points which helps us to come to a diagnosis. Xanthemia is another important bedside test that is usually done in case of a blistering disorder. This is done in the following method. Take a fresh blister and de-roof the blister. The underneath of the roof is scraped and spread up, and the material obtained is spread on the glass slide, and it is stained with Giemsa. And when observed under oil immersion, we see the acantholytic cell, which is a very large rounded keratinocyte with a large hypochromatic nucleus, a peripheral halo, and a clear rim of cytoplasm surrounding the plasma membrane. Now, two other investigations that helps are immunofluorescence and biopsy. When biopsy of a fresh vesicle is done, then this is the picture that is obtained. We get a blister in the stratum spinosum. This is the cavity, the basal membrane zone on which the stratum basal cells are resting. The cells are separated from one another because of the destruction of the desmosomes, but they remain attached to the basal membrane zone because of the preservation of the hemidesmosome. Another important test is the immunofluorescence when a perilesional skin is taken and